What made you become a plastic surgeon?
It's hard to pinpoint it to one, specific incident or event. I think, like many people, it's a culmination of the different experiences I had. I think prior to going into medical school and wanting to become a doctor, I probably had a similar opinion as most of the public in terms of what a plastic surgeon does, and that's mainly cosmetic surgery. I actually, when I wanted to initially go into medical school and become a doctor, it wasn't to become a plastic surgeon, and it was more looking at public health, community medicine, working for maybe the World Health Organization, or as we've seen over the last year with COVID, being a public health official. When I got just right before I got into medical school, actually, I had a family member who was born with a congenital difference, something that plastic surgeons treat. And this came as a surprise. And the question that kind of came to me as being this young, keen student, and hey, Vic, you want to become a doctor? Go look into this. And I was quite surprised when I did some research that plastic surgeons did this type of reconstructive work. And so that's probably where I first kind of got the idea, oh, wow, plastic surgery is more than just cosmetics. There's a big part of restoring function and form, reconstructive surgery, what it means to children and their families that are born with congenital differences, what it can mean for people who have been in accidents and had trauma, or people who have had cancer and need to have reconstruction to be made whole again. So that was probably when it first kind of entered into my mind. I still didn't know too much about it. And, lo and behold, a few months later, I'm starting medical school. And one of the neat things, and I went to Western in London, Ontario, and one of the neat things they did then, and I don't know if other schools did that as well, but I was very fortunate where they had assigned us a different rotations that we would just go for a half day, in our first year. First year medical school is largely classroom based, or was at least classroom based, lecture based learning. And, to sort of get your feet wet and start to put the seeds in your mind. The program, would assign you a half day to go, spend it with a family doctor, or spend it with a neurosurgeon. And, through the series of these experiences and rotations, I was fortunate enough to be assigned to a plastic surgeon. Again, that opened my eyes to the incredible breadth of work that plastic surgeons do. And, when I reflect back on what I do now and what many of my colleagues do and why we do it, I think it's because of the variety. We don't just operate on one part of the body, and we're not just limited to one area. And I think that's a big part of what we do, and keeps it exciting, keeps it interesting, keeps it fresh. Of course, we all have our individual areas that we might focus a little bit on, but as a whole, the specialty really draws you into that. I sometimes joke that it was just simply having a great mentor who was willing to teach and to spend time with me and to allow me to work on research projects with him. And if that had been someone from a different specialty, I could have very easily ended up maybe in that area too. So I think it is a good example of where mentorship and experiences and having good people to kind of help guide you. And that's something that I like to do now in my role in the medical school and teaching medical learners, medical students and residents, and is really try to give back to them the same kind of mentorship that I had, and sort of really kind of expose them to an area that they may not have considered. And one of the things that I like the most about when I'm teaching is someone who doesn't necessarily come in thinking they want to become a plastic surgeon, and they just think, again, much like I did and like many people do, that it has a very narrow focus, and then show them what we do, and seeing the kind of light go off in their mind where, hey, this is something cool, and this would be something that I'd like to do in my career. And so I think that's, you take these experiences, and you sort of the sum of these experiences kind of leads you to there. And plastic surgery is one of the more competitive specialties in medical school. So when you're a medical student and you have to decide what you want to do, that is a reality. And so you sometimes have some self-doubt. You think, oh, well, am I going to be good enough? Are they going to select me? Or are my hands good enough? And do I have the technical skills to be able to do it? Yes, you may want to do it, but will you get in? And so I think I was fortunate enough that that seed kind of had been planted early on, and it gave me time to do the research, to go on electives at other universities. I was very fortunate to have trained and done electives where we go and spend time with the different programs all across the country, from Dalhousie and Halifax all the way to UBC in Vancouver, and most of the programs in between. I had a great opportunity as a third year medical student, which we call our clerkship year, which is primarily hospital-based rotations, where you're having experiences with patients clinically, and you're no longer in the classroom, and you're kind of learning on the job. To go with this group called Operation Smile. And Operation Smile is a charitable foundation that will go to developing countries, underserved countries, and help children who are born again with congenital differences, in this particular case, largely cleft lip and palate differences. Kids who are, here in Canada, some of these surgeries are done at, age of 3 months or a year for their second surgery. And, the kids don't even ever really have a living memory of knowing that they were born with these differences. And you go to other countries, and I happened to be lucky enough to go to Siberia for a month. And, we were seeing kids, who were 15, 16, and, they didn't go out, they didn't leave anywhere. They kind of, lived their lives with a mask or a bandana kind of held around their face. Many of them had come from an orphanage. Many of them had been given up for adoption solely because they had been born with this difference, and their parents didn't either have a way to deal with it, didn't want to deal with it, and just kind of abandoned them, to be honest. And
Must have broken your heart to see that.
It is heartbreaking, but at the same time, the sense of community and the sense of spirit that the kids had together was very uplifting. You'd be surprised the things that you would think would be devastating, and it may be our own privilege sometimes that we forget. These kids were, that was their world, that was their reality. They didn't have, families, but they had each other, and they cherished that. I found the same thing before I went to medical school. I had the opportunity to work in Africa with a research organization called AMREF. And part of my research and volunteer work involved going to some of the slums of Nairobi. And again, same thing. You'd see, the poorest of the poor that you could imagine, people who didn't have homes, who lived in these shanty towns, and, didn't have shoes. And, on one hand, you would be, appalled and, heartbroken for their plight, but you'd turn and you see the kids, and they'd be playing, soccer on this dirt road, and they were happy. I don't mean to be presumptuous that they, wouldn't have, rather had different circumstances, but, even in tough circumstances, I think it's human resiliency, it's human nature. People find a way to find happiness. And I think it's about, perspective and reframing things in your mind. I think, again, we are very privileged here in Canada and North America and our society. Certainly there are times that we have experiences where we don't feel happy, and we feel stressed, and we feel that, woe is me. I certainly feel that way. But, you look around and you see these situations, and it makes you feel like, honored that you can do something to help. And I think going back to that experience in Siberia made me realize that, yes, I think I'm in the right career path. I think I would like to go. I would like to help people. There's many ways in medicine to help people. There's many ways to help people in all fields, of course. Medicine is just one way in terms of people's health. And, surgery is physically doing it, as opposed to, an internist who might do it with, physiology or medicine, and a radiologist doing it through imaging. We're all helping in our own way, but I found it, particularly rewarding to be able to help, with my own hands, and then see the change and see the difference right in front of me at the time of of our work. It wasn't something that I had to wait, you know, a year to see the results of an intervention or something that we would, prescribe to see if there would be a change. You see the change right in front of your eyes. You see someone come in with a cleft lip deformity, and then you see that lip repaired at the end of your case. And it was very, very fulfilling and rewarding.
How many degrees do you have, Dr. Chahal? You knew
If
I
you
was
ask
going to
me,
ask that.
too many. Interestingly enough, I do have 6 degrees, something that I've become somewhat known for. Certainly, to become a plastic surgeon, you do not need 6 degrees, and you would need 3 degrees. But the 3 that I have afterwards came after I had become a plastic surgeon, and kind of spoke to my a lifelong learning. Even the 3 degrees, while I'm very proud of, and they hang very prominently in a place of pride in our house, they're still learning every day, and they're still kind of staying on top of the latest technology, staying on top of the latest techniques. I'm not alone in that way. Most doctors, most surgeons, most plastic surgeons are doing the same as well. The degrees gave me the opportunity to sort of expand interests beyond the typical role as a plastic surgeon. And so the 3 degrees are 3 master's degrees that I did after I had finished my residency and was working as a plastic surgeon. The first degree I did was an MBA, focused on physician leadership and healthcare management. It's an area that speaks to me, and it speaks to a lot of my colleagues. As physicians, we do have to be conscious of the fact that we are stewards of our healthcare system. And one thing that I've noticed that's kind of happened over the years, and speaking to some of my older colleagues, is that physicians were always the leaders when it came to hospital and healthcare systems. And we kind of abdicated that a little bit, and we allowed non-physicians to come in and make some of the decisions that involve our healthcare. As physicians, we can sit there and complain, or we can sit there and decide, let's have a voice. And to have a voice, you need to have an understanding of the language that they speak, sort of in the C-suite, so as they call it. So you need to understand the corporate dialogue. You need to understand the corporate infrastructure. And if you want to, you can easily get a seat at the table. But if you want that voice to count, if you want that voice to make a difference and to represent not only a physician interest, but also, most importantly, the patients that you care for, the patients that you want to advocate for, you need to have the skill set. And I really enjoyed the MBA. There was a specific MBA just for physicians, tailored to our interests and our goals. And I found that to be very helpful. So that was kind of that was kind of started the journey. Again, I wasn't planning on doing 3 master's degrees, but you do one, and it's kind of like they say with board work. They say, board work begets board work, and you start on one volunteer board and you end up with another before you know it. And it was the same kind of idea. The spark that came from going back to school and learning. At that point when I had started, I was about 6 years out from after finishing my residency and 6 years of working as a surgeon. And it was, just a great opportunity to get back into it and to get back learning. You spend so many years in school, you almost kind of miss it. You become conditioned to being a lifelong learner. And from there, I did my second degree as a Master of Education, at Johns Hopkins, and again, a specific program to help healthcare providers become better teachers for their learners. A big part of being at an academic institution like the University of Calgary is that you are involved with having medical students around, having residents who are training to become surgeons and even other types of specialists. And we've always kind of taught them informally. They sort of show up, and it's kind of a bit of an apprentice type model. They kind of watch you, and you kind of show them a thing here or there. But as we've seen, there's a growing trend towards wanting to bring more formal teaching models. These are adult learners. They have different needs. They have specific needs, and they have a short amount of time to learn a lot of information. And as their teachers, we can do them a great service if we can have skills to help them with the things that they need to become, colleagues. And so I think that, whether it's, from curriculum design and program development, and a big part of my uh, master's and my sort of thesis project of it, if you will, was centered around mentorship. Again, mentorship tied into the leadership from the physician leadership perspective from the MBA, bringing it into mentorship when it comes to teaching, when it comes to, helping, our trainees learn about the business of medicine. That's something that we aren't traditionally taught in medical school. It's generally a bit of a taboo subject. Its barriers are breaking. We are starting to talk about it a bit more, knowing that you can't just, think that you'll practice medicine in a vacuum. You have to be mindful of running a practice, being a small business owner, having employees, dealing with all the things that go with that is an important piece that we need to start advocating for our learners. I know from my wife's experience in the dentistry model, they do a better job in dentistry, and in medicine we've lagged behind. So that is something that I'm excited about as a piece where I'm kind of merging now that MBA experience, that business training, with the interest in medical education, and having bringing that to the forefront. And then finally, if that wasn't enough, the third and final degree for now, it was a Master of Public Health, and that I was able to take at Harvard University. And in that two parts, was focused in epidemiology, and it was a research-based degree. But it also fulfilled that, childhood dream of going to Harvard. It's something that, I think a lot of kids that are, academically inclined would put on their bucket list. And over the years, it kind of got away from me and was something that, didn't think was going to happen and was okay with. But when an opportunity came up to do this degree, I thought, hey, why stop now? Go for 3. And again, different experience. Much more challenging experience for me because it was very bio stats driven, very mathematical, a lot of modeling. Again, I really got out of my comfort zone. Many of the students I was in that program with were much younger and earlier on in their careers. And at that time, having 2 young kids and a wife in residency and moving across the country, it did add a lot. And I was very thankful for my classmates for the extra help and latitude they granted this old guy as he tried to, kick the can one more time, so to speak.
Did you feel, I guess, does it bother you at times, or did it bother you at times seeing blood, cutting people open as a surgeon?
Oh, good question. No, I don't know if that makes it morbid or makes me realize that, was an okay career choice. I think there's a bit of a somewhat of a joke in medical school that if you don't like blood, then you end up becoming a psychiatrist. But, I think I was never something that I was squeamish about, and I wasn't squeamish about it even before medicine. And I think if I was, it may have maybe led me to a different path. Maybe if you think about the stereotypical jobs they tell a lot of kids to be, let alone the kids of immigrants, doctor, lawyer, engineer. If I was kind of squeamish at the sight of blood or, bodily fluids, then I would have maybe chosen an engineering or a law path. I think somewhat self-deprecating, I can say that I don't think I was smart enough to be an engineer. So that would have crossed that off the board. And then I, maybe would have looked at law school. The reason I smiled and laughed a little bit when I said 6 degrees for now is that I have always loved the idea of studying law. I'm not going to do it right now at this stage of my career, but again, sticking to this philosophy of lifelong learning, which, I think I've always believed in and have definitely lived by example. I could see myself, when it comes time to retirement, if they'll take me, enrolling in law school, not necessarily to become a lawyer, but to study law, just from an interest point of view, just from an academic and intellectual curiosity. So yeah, I think to answer your question, if I had been squeamish, I wasn't squeamish about blood. Maybe even from again, in a bit of a perverse sense, I loved anatomy. I think I remember being a undergrad student and being interested in uh, potentially going to medical school. And, at that time, you don't know much about medicine. I didn't come from a family of doctors. What do you know about, medicine? And for me, it was anatomy. And I can go back and think about even in my childhood, my grade 4 science project involved a human body. Project, and I remember having these different plastic cadaveric specimens that we had borrowed from my family doctor, our family doctor's office, and he was kind enough to encourage me along. And I've always had a fascination for the human body and anatomy, and sought out anatomy courses where I could. Both in high school and undergrad. And so going to medical school, a big part of it was, hey, I get a chance to learn the anatomy of the body. And, when I say it like that, it makes me think, well, of course, then I was going to be, maybe drawn to surgery. If you love anatomy, you're going to be drawn to surgery, because surgery is basically, anatomy, and it's taking anatomy that may have been disrupted or altered either by accident or by birth or by a cancer, and trying to restore it. And that's actually the very essence of plastic surgery, is restoring that anatomy, restoring that form, restoring that function. And yeah, I think that's.
Do they call you for? Are you a trauma surgeon as well? So would they call? Are you on call for that?
Yeah, so part of being a plastic surgeon is trauma surgery. Trauma surgeons, traditionally, if you hear the word trauma surgeon or you see it on TV or in the movies, they're usually, if you think about it, they're dealing with the traumas that are like a gunshot wound or a bad accident. You see them in the emergency room, and then they're taken straight to the OR. But typically it can be divided down to the different body parts that you're dealing with and the different levels of injury. So as plastic surgeons, yes, we deal with trauma. We do a lot of trauma related to hand trauma from, again, accidents and injuries from playing sports or, anything where you
You've
kind of hurt.
always been interested in hands. Why is that?
Um, I find the anatomy of the hand very, very fascinating and very intricate and very complicated. The way it has worked in Canada, at least, it's not like this everywhere in the world, but the sort of subspecialty of hand surgery has fallen under the domain of plastic surgeons. So all plastic surgeons are trained to be hand surgeons and have hand surgery as a big part of their training. Now, not all plastic surgeons will go on to continue to do hand, and there are some hand surgeons that are maybe orthopedic surgeons that have done extra training to become hand surgeons in Canada. In other countries such as the US, the domain of the hand and any injuries and issues that relate to the hand tend to default to orthopedic surgeons. And when we're on call, that's, a big part of what we're going to see, because people hurt their hands. The number one injury people go to the emergency room for is injury to their hand. Again, for so many different reasons.
Have you seen
and that's what we do when
fall
we're on
down and maybe a bottle breaks their hand by mistake?
Exactly. So you'll have everything from a workplace injury where someone catches their hand in a machine press, or cuts it at work while they're chopping vegetables and cuts a tendon, to people, playing sports and having a, soccer ball bounce off the tip of their finger, causing an injury to a tendon, or, sometimes they're self-induced, people punching a wall and having a boxer's fracture to a metacarpal. Lots of different ways in which we can get there. And so we will be on call typically about for 1 week a month. It can be quite challenging and stressful because we continue to work and do our regular scheduled activities, both in the office and in the OR during that week. And the call work that we do is kind of over and above that. So it can be a long week, and a long week where you are have to be ready to go at a moment's notice and be back at the hospital to respond in
I mean,
15
not only
minutes.
are you mentally drained, you are physically, I'm sure, exhausted.
Physically exhausted, absolutely. Some of the cases we do, if we're under the microscope, can be 8 hours, and it can be through the middle of the night. And it's hard enough to be up all night after you've worked all day, and let alone to be under a microscope. I think the other thing is just also the emotional impact of it. We see those are the unpredictable cases. Those are the unfortunate cases, the cases that people weren't expecting. You see people who are about to die. People, again, thinking of what the stereotypical notion of a plastic surgeon is, don't think that we would be dealing with some of these things. Again, I've had people say to me, "Oh, you're on call. What's the emergency? Someone needs a emergency a breast implant." But they forget that part of plastic surgery considering we are responsible for the body's largest organ, the skin, can be things such as flesh-eating disease or necrotizing fasciitis, and really bad infections, things that need to be taken to the operating room and debrided and cleaned so that a patient doesn't die. And we're really trying to save often their limbs and their lives. And those cases can't wait. And those cases, it seems to come, in
I
the
think
middle
it's
of
like
the night.
it's called skin grafting. I'm not too sure, but if, say, something was eating your face alive, you'll take it from another part of the body and you'll move it here. And by the time
Yeah.
this heals, this is already eaten up again. So you have to keep moving around the body to protect.
Yeah, it's staged, and again, a lot of the things we do are staged in the sense that first you have to control the initial trauma or insult or infection. So the first priority is obviously controlling the infection, eliminating the cause, stabilizing the patient, and that may take a couple of operations of just going back to getting to a point of where there's healthy tissue, where the infection is cleared and the patient is stabilized. And in those early stages, we're worried about stopping the infection and saving the person's life. We're not worried about what it's going to look. Of course, patients have that worry and their family members do. We have to start thinking and planning in the back of our mind what we're going to do. But first and foremost, it's about limb and life preservation. Once the patient is stabilized, once the infection is settled, once the wound is ready, because you can't do reconstruction in a wound that's not able to support what your repair will be, then you can consider your, reconstructive ladder, as they call it, in terms of the different options that you have. And we can do things from using tissue that's local and nearby to skin grafting, as you mentioned, to free flaps, where we're bringing tissue from distant areas and reconnecting them. And it will depend on the size of the defect and what's been lost. We have a saying in plastic surgery that we like to reconstruct like with like, and that's basically saying is if whatever tissue has been lost, that's the kind of tissue that needs to be replaced, whether it be skin, muscle, cartilage, bone. And so that's where that's the part where I think most of us do what we do, and we're really drawn to this specialty for that reconstruction. Obviously, the first part of it is important, and making sure that the patient can get there. Sometimes that's done by us. Sometimes it's done by our other surgical colleagues, and then they ask us to come in to help them with that the final phase.
Is there I mean, this is such a bizarre question, but is there a way for individuals to not, or when they're doing their skin grafting, instead of getting it from their thighs or their glutes or whatnot, couldn't you get it from someone that's donated their body and take their skin?
Good question. There are different aspects to that.
Mm-hmm.
Simply put, the reason why we can't usually have someone else donate the skin, like a parent to their kid, is because of rejection. And so if you think about that, a skin graft from someone else is the equivalent of like a organ transplantation. And we'll do that when we have to for life-threatening and life-sustaining needs. Yes, if you need a new heart, you will get someone else's heart, and then you will have to spend your life basically fighting your own body, who's going to be trying to reject that organ they're going to feel, your body's going to treat that as a foreign body. And so this is why people who are transplant recipients are on anti-rejection drugs. They're on medications so that their body doesn't reject that organ. And so when we are talking about, you know, doing a, you know, skin defect or soft tissue defect or something that isn't necessarily life threatening at that point, if it's relatively small, then it wouldn't make sense to put the patient through the increased risks of being on anti-rejection medications to borrow someone else's skin. And typically we are able to find what we need from people's own bodies. We've been very resourceful. And again, another thing that we like to say about plastic surgery is that we, you know, borrow from or steal. There's a saying, steal from Peter to pay Paul. And so we will borrow where we feel that we can take the tissue without any significant deficit or downside, and use that tissue from the person's own body, and it'll have the best chance of surviving, which is most important. And we call that specifically with grafts take, and you want the skin graft to take. If it doesn't take, it's just going to be a dead piece of tissue that has to be debrided and removed once again. And so that's the kind of, you know, simple version of why we don't borrow skin from someone else to close that. Now, there have been great strides and advancements, and, you know, using stem cells, they're now able to, you know, generate cells and basically produce new skin for a patient. Those are done in, you know, relatively rare circumstances, where if someone has had, let's say, a full body burn and there's just absolutely no skin on their own body to take from. But again, most of the time, like I said, we're able to find somewhere in the body where we can borrow skin and tissue from the person themselves, and then not have to worry about that.
How do you stay awake and stay focused for 8 hours, standing up, being in this zone without any distractions? How do you get in that zone?
It's a good question. You know, you do it because you have to do it. I guess that's the simplest way I can describe it. When I was in medical school, my roommate used to joke about how he could stay up all night studying for, you know, exams when we were trying to, you know, prepare. And, you know, he didn't drink coffee, and he would say, well, fear is the reason what keeps him going. And, you know, I would say, not fear in the sense that we're scared of what's going to happen, but, you know, a heavy sense of responsibility that, you know, patient has put this trust in you to make them better. And at that time you're focused, and there's no other option. You just, you know, you don't get tired. And I think that's, you know, an analogous situation might be with what many, you know, young parents feel when they're dealing with young children that aren't sleeping. It's you do it because that's what's required. And you know, is it hard on you? Yes. You know, would you like to not have to do it every night? Absolutely. But when the time calls, you know, you step up and you get it done. And I think that's just, you know, part and parcel. You can see that in our volunteers and people as they've been, you know, dealing with COVID. You can see it in our military. You can see it in our, you know, police and fire members. With, you know, when there's an emergency, you just do it. Maybe there's a bit of an adrenaline rush. Maybe there's a bit of a, you know, a surge where you're like, you know, it just got to get done. The next day you feel it. I think as we get older, at least speaking personally, it gets harder. When we're younger, and I think I try to, you know, tell the medical students and residents as they come through about this too, is that, you know, when you're young and you're in your 20s and you're on call and you're up all night, it's exciting. You relish it. You get this exciting case. And as you get a bit older, getting up in the middle of the night, staying up through the night gets harder and harder. And certainly in my personal life, it's made me kind of not voluntarily like to stay up super late because I you know, really want to appreciate and enjoy the rest when I can get it.
What do you do to unwind with your family when
Good
you're away
question.
from all of this?
Yeah, I think, a big part of being able to maintain and be able to do this is having, for me at least, a loving and supportive family. It's tough. My wife is also in a heavily busy and demanding career in many ways. She's has a much harder career as she has to deal with children. She enjoys it and is very good at it, but it can be very draining as well. And so we both can often come home from work having been drained, and we have made it a point of effort, and it has taken time and a lot of practice, especially on my end, to say that, like, when we come in through the door, we leave work where it is, and then now's our time for our kids. Our kids are relatively young; they deserve to have our full attention. And I think being mindful of the fact that we need a break, we need to turn off, we need to you know reset our minds to other tasks. And I think the good thing about young kids is that they'll again force that on you. You don't have to ask them, and you don't have to think too hard about it. I walk in the door, and my kids will want to play Lego, or they'll want to wrestle, or you take off that surgeon's hat, and your dad, and you're just busy and enthralled with them. And then we feel so fortunate that we're able to spend that time with them. I know not all parents and not all careers allow that. And so being grateful for even that opportunity. I don't take it lightly that I am able to come home at a decent time and spend time with my children, a little bit before dinner, during dinner, and then after dinner. And we try to do family workouts every night. And then, get the kids off to bed. Leaves a little window for my wife and I to spend some alone time. And one of the things that we have been doing a lot during this pandemic, like I think most people, has been watching a lot of shows on Netflix and Prime Video and Crave and things like that, and recommendations. And there's nothing better than when you've gotten a great recommendation and you really enjoy the show. And sometimes we just really look forward to watching that, and are kind of disappointed once that show ends, and are kind of looking at, well, what's the next one to come. And you don't honestly want the show to end because you're so into it.
No, of course. If someone watches a show like a crime documentary, they have a tough time falling asleep.
Yeah.
After surgery, sometimes, you're trying to sleep. Do you start thinking, oh, I wish I could have moved that capillary here or whatnot, or I should move that vessel here? Are you constantly thinking, or have you learned to let it go?
Yeah, no, I think I am. I think, again, I think it's part of the job. Truthfully, I would say that I probably think a lot more before the surgery, and before the case comes up. And so even knowing that you have the consult coming, or definitely once you've booked and have the patient ready for the OR, in the days preceding, and definitely the night before, I'm thinking, okay, how am I going to approach this? What are the things that I'm going to be expecting? What am I going to do if things don't go that way? And how can I be prepared? I think it's important to sort of have that dialogue in your head, so that when the opportunity arises, or the crisis arises, you are able to manage it, because you've kind of played it out in your head. And I think, again, I don't do it for this reason, but I've heard, borrowing from the sports world, that's what a lot of the top end athletes will do. I'm a big football fan, and, quarterbacks, guys like my guy Peyton Manning, they will sit there, and that's part of their preparation, and watching game film and thinking about what they're going to do. And when they see the defense show a different a certain setup for them, that how are they going to handle it, what's he going to audible, what's he going to change, and kind of bringing that into our world. After the fact, I think preparation is key. Thankfully there's not too many times where you want to replay and revisit things and how they went, unless there was a problem. And unfortunately, that is the nature of surgery. And the nature of humans and medicine in general, things don't always work out as we would hope they would. And so sometimes you may replay how you may have done something differently, and how you're going to manage it and how you're going to fix it and how you're going to, deal with it. It's easy to have, to say that you have great results every single time and that you never have to deal with it. But I think something that I pride myself on is how I handle and how I like to approach, when things don't go well, and, you have to explain to patients that, this wasn't the outcome that they were expecting, certainly, and certainly not what I was expecting, but how do we pivot from that? How do we adjust, and how do we move forward? I think that's, something that is very important in what patients should be looking for when they're looking for a surgeon, is how are they going to manage the problem and how are they going to deal with things when things don't go well.
What was one of your proudest surgeries that you've done? One of your longest surgeries, and then one of your proudest surgeries.
Okay.
Vic, I think you have that one that you talk about all the time, the hand one with the guy and he's cut up everywhere. Do you want to say that one? Or you probably have another one.
Yeah, I mean, we could do that one, or I'm just trying to think of another one. There's so many. It's I think, we certainly, I can talk about memorable or ones that kind of still jump out at you in your mind. But again, the one thing that's important to remember as a surgeon is that you may do many, many surgeries in your career. You will do many, many surgeries in your career, of course. But for most patients, when you're working on them, that's their only surgery, or that's definitely their only surgery that they're going to be having you related to what you're doing for them. And so I really try to, keep that in mind, that, this isn't just, surgery number, 874 of this, particular procedure that I'm doing, that this is surgery one of one for this patient. Certainly there's ones that, stick out a little bit more than others. And it's not because of the person per se or the problem, but it's maybe sometimes the, circumstances of it. And so one surgery that always sticks out in my mind is one of the first ones. And, when you become a surgeon, it's after many, many years and you're like, okay, finally I'm done. And, then all of a sudden you go to start work and you're like, oh, I'm done. That's it. It's just me. There's no staff surgeon to review the case with. There's no one else in the room to kind of watch you to make sure you're doing okay. It's all you. And so I think invariably for most surgeons, those kind of, watershed moments hit early on in their career. I remember distinctly, it must have been my first week in working. It was a Friday before Thanksgiving. I wasn't even supposed to be on call. And then I had kind of, said, well, you know what, this is great. I'm working and, starting to pay off your student loans. Sure. Why don't I volunteer to take call? And that's what sticks out. Number one is that I volunteered to take call. And as you go along and you meet surgeons as they get older, you know that no one's volunteering to do call. They do the call that they're assigned and usually not more than that. But, here's a young, keen surgeon fresh out of his training, volunteering to take call, and thinking, oh, it might not be that busy. And my wife and I, we were going to head out for dinner. We didn't have children at the time, and, just excited. We're living in a new city, new job. Just, we had only been married about 6 weeks or so.
Oh, wow. So everything is exciting. New.
Two months into, being newlywed and, just getting settled into our lives. And, I get this call and it's, about a 4-year-old girl. And, she was running, she had glass in her hand and fell, like we said, relatively, innocent and harmless. And, it could happen to anyone at any second. And she just, basically completely lacerated her entire hand. And, they showed up in the emergency room. At this time, we were working in Ontario and we're working in a place where they didn't have a dedicated children's hospital. And so, yeah, you're on for plastic surgery. This is a hand injury. They need you. So you come in. And so, you come in and, you're meeting the parents and they're just so devastated and heartbroken, and again, at the time, not being a parent, I probably may not have been able to empathize as much as I can now and know that, they would have been just devastated because they would blame themselves, and they were blaming themselves for, why did she have the glass, and, why was she running? And, these are things now, once you have kids, you realize that, they happen, and it's just part of childhood, and no parent is able to watch their kids at all times and prevent them from having any injuries. And so they're beside themselves, and I'm trying to tell them, okay, we'll try our best, and we're gonna fix things up, and we'll go in and take a look. And she was young, and they had her all wrapped up, and so let's just get her to the operating room, and let's get started from there. And we get into the case, we get started, and the one thing that really kind of jumped out at me, and still I think about, is that when you're in the operating room and you've prepped and you've draped out the patient, they're largely covered with sterile sheets, right? You want to keep a sterile field, you want to minimize the chance of infection. So out of all these blue drapes, there was just this tiny little 4-year-old hand sticking out, and then that was your canvas, what you were going to work with and what you needed to fix, not only for her function and for her life, but for her parents too. And I remember getting started and, being super keen, and then, get a little deeper, and you're like, oh, this is a little more complicated than, what I was thinking. And, oh, this is, wow. Oh, she's cut her arteries. She's cut her tendons. She's cut her nerves. Her hands were so small that the structures that she'd injured were even smaller. And again, not being a pediatric plastic surgeon, and not it really being the focus of my practice, it was, in my opinion, extra challenging, because now all of a sudden you had this tiny hand. So, you think, okay, well, this should probably be done by someone who's a specialist in pediatric plastic surgery, someone who does this more frequently. If this was my child, that's the level of expectation that I would want. And so this is what I want to do for this patient. So, you're getting on the phone, you're calling, the academic center where there's a children's hospital. And, luckily enough, we had 3 that were in relatively close proximity to the city we were in. So you call the first one. Yeah, no, sorry, we'd love to help you, but you know what? We don't have any beds. So sorry, can't help you. You're like, okay, great. Okay. Well, call the second one. You know what? Yeah. Hi, you got this case here. I really could use your hand. I don't think I can do this by myself. Sorry, can't help you. Okay. Call the third place. Nope, can't help you. And then all of a sudden it's this like, oh my God moment. Like, it's me. That's it. It's me or nothing. And then wondering, how did I get myself into this? And, why did I volunteer? So you put those thoughts aside and you say, just got to get this done. And, I always think back to that, because I think, that here's a situation where, I was definitely in over my head. I was definitely outside my comfort zone. I was doing something that I felt, someone else would be better equipped and prepared and experienced to do, but those options weren't available. And so you just get down to task and you start working away. Now, did the surgery take me longer than it would have taken someone else? Of course. But in the end, we got there and she had a great result. I surprised myself, first and foremost. I think, again, for me, that was the story of overcoming some fears, getting that first hard case under your belt, realizing that you have, and being in Canada, we're lucky, all the training programs are so great, but knowing that they train us well, they don't kind of let us out on our own until we are capable, even if we have some self-doubt, and that, if you just start working away, you get there. You can tackle anything if you take your time, break it down into individual steps, start fixing, in this case, it was like one structure at a time, start with her blood vessels, fix her nerves, fix her tendons, one step at a time. Wow. So that's one case that always jumps out at me in terms of just from
no, I appreciate that.
The first kind of scary case that, you didn't get the help that you could have and would have liked, and in all honesty should have had. And then, there's other things along the way too. Certain ones that are, tug at your heartstrings. I had a tough case, in the summer and during COVID, it's been hard. I saw a lot of patients who came in very sick that we don't normally see and they came in with, life-threatening infections and flesh-eating disease, things that, in normal times may have been treated with antibiotics early on, and they wouldn't have even had to come in. And here are patients who, for one reason or another, didn't have that access, didn't have that opportunity, didn't get that care. I call them COVID casualties in the sense that they didn't have COVID, but COVID led to their um, uh, illness and ultimate death. And that's hard. And that's hard to see. It's hard to deal with. On top of, the challenges that we all face just in our personal lives with COVID, the professional challenges we've had, the challenging cases we've seen, the sad and potentially avoidable outcomes, are hard to kind of swallow. That's
No,
been
of
hard.
course.
And you have other cases that jump out at you and they kind of affect you. We see as part of plastic surgery trauma, a lot of dog bites to faces and body parts and tips of noses and lips and ears missing. And again, it probably makes you a little bit more reluctant to have a pet. I can say in full honesty, I don't believe it is the pet's fault the majority of the time, but they are animals, and sometimes bad things happen with little kids, and no one meant for it to happen. And the end consequences, though, is that there's some significant life-altering and disfiguring injuries. And so that stays with you. And so sometimes, you become Captain No Fun for your kids because you tell them, hey, you can't go on that trampoline. Hey, you can't play with that dog, or be careful, out on your bikes because, you've seen all the injuries, you've seen all the bad outcomes that happen, and you want to shield your kids from that.
As a parent, how do you sometimes say, okay, let's just do this. It's okay. Let them be children.
Yeah, it's hard. It's so hard. That's something I struggle with. I'm probably more of a, helicopter parent than I should be. And, my kids would like me to be. It's hard. I think, it's hard for all types of parents, for whatever, professional background they may have and work background. Certain parents, it's just a philosophy that you kind of have. I definitely am someone that, wants to keep my kids within, arm's distance more than let them go. Being in medicine and seeing the things that I've seen from a potential injury point of view, yes, that amplifies it. It's hard to maintain that balance. I think, you just have to, you have to trust your kids. You may not trust the world that's out there, but you have to trust your kids and,
Mhm.
give them the skills and the preparation. I mentioned earlier about, preparing well for, surgery and preparing well for, the work that's to come. And I think it's the same thing with being a good parent is making sure that you're preparing your kids and maybe preparing yourself for the inevitability of them taking those steps. And, there's that saying that, once you have a child, your heartbeat beats outside your body. And I can completely see that. And I'm still fortunate that my kids are relatively young and they have to be in close proximity to an adult, and definitely us as parents. It's going to be a big adjustment as they start to get older, and we're going to have to let them go a little bit more as they get into their teenage years.
You're a big football fan. Do you look at Peyton Manning as an analogy when you're doing surgery? Is that what you do? At times,
Yeah.
Peyton would do this or the steps.
Yeah. I mean, I try to. I mean, I would stop a step short of saying that he's like a role model or an idol, simply because I am a bit older than him, and so I don't want to say that. But yeah, definitely, I think his approach to preparation and his focus. He may not have always had this, the outcomes he wanted, and I do understand that, when it comes to sports and in determining and ranking the all-time greats and of late, the term the GOAT, greatest of all time, has become really popular in our vernacular. He doesn't rank at the top when it comes to his overall championships. But I don't choose to evaluate quarterbacks just by their championships, because that's only judging them by the team outcome. And what's always impressed me about him was his preparation, his approach to the game, knowing what's going on in the field, anticipation, knowing what his defenses were going to do against him and trying to stay a step ahead. I think he's the first one to say himself that he, that's how he dominated, and that's how he got to be where he is his, approach to the game, his preparation for the game. And yeah, if I could say that I borrow that a little from him, then, that's a high honor. I must say, and I didn't allude to it earlier, but when I did my MBA, I actually did it at the University of Tennessee. And that's because I'm a Tennessee Volunteer fan. Why am I a Tennessee Volunteer fan? That's where Peyton Manning went to college.
Interesting. Okay. Now, this all makes sense. So when you started the Calgary Plastic Surgery Center last year, actually, was it June or May when you had opened?
We officially opened and started seeing patients in July. The build out and starting sort of the clinic preparations probably a few months before. Basically, it coincided with COVID, and that's what I always tell myself, is that only I would get myself into a situation where I'm building and starting a clinic during the greatest pandemic of this generation.
Of course. But the University of Tennessee's color is the orange, and I think CPSC is orange.
Very, very observant of you. Yes. So orange is my favorite color. Orange is University of Tennessee's color, and orange is the theme color at the Calgary Plastic Surgery Center as well.
What made you say, okay, now is time. I've done all this in my life. Let's now open a clinic on top of COVID?
Yeah, good question. Good question. Yeah. And so, yeah, one thing I always, will say is that, the Calgary Plastic Surgery Center and this new clinic has been open for a year now, but its foundations have been going on for a lot longer. I've been a plastic surgeon for about 14 years now. And so the ideas have always kind of been there. We were in Ontario for about 8 years, and moved to Calgary about 6 years ago. And
you were a head surgeon in Ontario, weren't you? As chief surgeon or a head surgeon, is that what they call it?
Yeah, so I was the chief of our division of plastic surgery at two of the hospitals I worked at in Ontario, and was on a trajectory towards greater, I'd like to hope, leadership positions within surgery. We had kind of had a thought that we'd like to move to Calgary. My wife's originally from Calgary and has family here, and I have family here as well. My grandparents lived in Calgary, and we used to come out and visit almost every year. My parents were even actually married in Calgary, but raised their family and had their careers in Ontario. So my extended family was all here in Calgary, and as things turned out, we, some of my relatives, my uncle is best friends with my father-in-law from many years working at CP Rail. So Calgary was always kind of on the horizon. We had been married here. When the opportunity came here to work at the South Health Campus, which is the hospital that I have my main privileges and operate out of, we jumped at the chance. And so, I've been working out of the hospital for the last 5 years here, and enjoying it, and I still continue to do, and that's always going to be a big part of my practice because of the nature of the work that I like to do. But I also kind of recognize that, with the nature of plastic surgery, there's many things that I would like to do and offer to my patients that need to be done outside a hospital and outside of the public healthcare system. And so the Calgary Plastic Surgery Center really allows me to bridge the two, aspects of my career, both the reconstructive publicly funded surgeries that we do, and also private cosmetic work.
Interesting. Now, when people have, carpal tunnel, do you guys also treat them, or how does this work?
Yes, in terms of like hand surgery, as we were talking before, not only is it for trauma and for injuries, but there are a lot of elective conditions of the hand, and they're very common and very frequent. And so, carpal tunnel is among the most common conditions we see related to the hand. Carpal tunnel is basically a pinched nerve, and from repetitive activity over the years, and who doesn't do repetitive activity, whether it be at work or with our hobbies and activities, we're always all using our hands. That nerve, as it gets pinched, can lead to people having a bit of numbness and tingling in their fingers, particularly at night, and it can disturb their sleep. And so it's a relatively simple procedure for us to release a ligament that's compressing on that nerve, and that's called a carpal tunnel release. So
How does
carpal tunnel.
someone know if they have carpal tunnel?
Yeah, the classic description people will say is they'll have numbness and tingling in their fingers. And especially if it wakes them up at night, that's when it's getting to the point of it being something that should be further investigated. People might say that they're, dropping objects, or their hands go numb when they're driving or reading a book, or, typing.
As a surgeon, do you have to stretch your hands often, or do you have to do certain exercises to keep you sharp?
Yeah, good question. I think it's not something that we're taught, and it's not something that, we probably make a mindful note of. I think definitely as I've gotten older, I've started to be more cognizant of, my body's limitations, and making sure that it's not even as much as my hands, it's more the neck and back, making sure that you're operating with the bed at the proper height, that you're not kinking your neck and putting yourself in an awkward position. Now, sometimes certain cases and certain procedures are going to force you to be in an awkward position. And that's, that's hopefully something that you're not going to be in a position that's uncomfortable for too long, because you really start to feel it more as you get older, and you've done it for a long time. But I am very conscious of trying to stretch and trying to make sure that I'm being and working as efficiently and ergonomically correct as possible. Definitely.
So I'm going to ask you two questions, Vic, and then we're going to move on to the technology and all that, and we'll be good. So
Sure.
there's two myths, or I guess questions I have. Are Crocs comfortable?
Are Crocs comfortable? Okay, so I don't wear Crocs, but I would imagine that they are. We wear kind of Croc-like shoes, I guess, that when we're operating, and they basically, the real reason we wear them more than anything else is that they're easily cleanable and wipeable. So we all often wear them in the OR. They tend to be pretty comfortable. Again, I don't know if it's just the nature of the fact that you're so focused on your work. I don't really think too much about my feet, and I'm lucky with the nature of the work that we do. We're not always standing on our feet for the entire day. There are moments where we're able to sit, whether it be, consulting with the patient, or for certain hand surgeries, we will actually do seated. And so that makes, gives you a bit of a break.
Mm-hmm. The other question is this. We see it a lot in the movies. If someone cuts off their hand or finger, you can throw it in a bucket of ice and bring it to the hospital. Is that true?
The shows and the things we're seeing on TV are getting closer and closer to reality. They must have great medical advisors on. I'm sure that's a great job, side gig for a doctor if you're in Hollywood, is be a medical advisor. And so a lot of the things that they shout out and orders that they'll say as a patient is crashing are accurate. We do suggest that if someone cuts off their hand, unfortunately, or their finger, is to put it on ice. Now, you wouldn't want it directly put on ice, because that'll damage the tissue. And so what we often will tell patients, or let's say, we get a call from an outside emergency room department, is, to wrap it with a, saline or saltwater soaked gauze, put it in a Ziploc bag, and put that bag on ice. And so that you're not having direct burn injury from the ice to the tissue itself, because that can damage the tissue and then not allow the replantation or revascularization as necessary.
Interesting. Now, the Calgary Plastic Surgery Center's got some remarkable technology that I don't even think our city has seen. How did you find this technology and what made you bring it to our city?
Oh, good question. Yes, definitely. We have technology. We're I believe, the only clinic in Western Canada that has all the BTL technology, which is really centered around non-invasive body contouring. Different technologies for different needs. Everything from radio frequency that's going to help with skin tightening, to high definition electromagnetic energy to build muscle and strength. And so we kind of came about it somewhat, serendipitously, as is often the case. We were at a conference in New York, my wife and I, and we started to notice that every other speaker at this high-end aesthetic and cosmetic conference was talking about this new technology and how they were using it in their practice and all the benefits that they were seeing. So naturally, we were intrigued. And while we were actually still at the conference, we reached out to the Western Canadian rep about possibly learning a little bit more and seeing the technology firsthand. And the thing that ultimately drew us to bringing it into CPSC and making it a core tenet of our philosophy, this idea of non-invasive body contouring, where patients don't need to have scars, they don't need to have significant downtime, and they can see achievable results in a relatively short time frame, was the fact that we tried it ourselves, and we wouldn't want to recommend or advise any patient on something that we haven't had firsthand knowledge of. And so we tried it and we experienced it, and we became believers, and it just becomes another tool in our armamentarium to offer patients other options besides surgery. Now, having said that, there are instances where, you still need to do surgery. It's not a surgery replacement. I like to call it not even a surgery alternative. It's probably best described as a surgery enhancement. Patients who have this sometimes still need surgery. Sometimes people who have had surgery can still benefit from it. It's just technology has finally caught up. There was a time where, there weren't many options and people had to undergo the knife, so to speak, and that was the only option. But now we're finding that as improvements and changes with technology are growing, and they're growing, by the year, we're able to offer a lot more in having consultations with patients, really getting the feedback that they appreciate, not undergoing the knife as much as, I might like surgery as a surgeon. I can be fully cognizant of the fact that not every patient wants to have surgery, and not every patient needs surgery. If we can deliver results for patients without having to put them under the knife, then and most importantly, the risks that are associated with it, then I think that's a good situation.
Some of the technology you have, I was looking online, I said, holy smokes, the one where you stand on it and it takes a 3D model of your body, and then you can utilize that to see how much fat you have and BMI and whatnot. What made you think, hey, this is another thing we should add to our clinic for our patients?
Yeah, I think a large part of that is born out of, again, this is a results-based industry. People want to see improvement. Certainly patients like to feel the improvement, but sometimes, you need to see it to believe it. And I think it's important to have good technology, not only for, good record keeping, but so sometimes you can show patients exactly, where the improvement has been. I think one of the things that we've noticed, and it's a good thing in the grand scheme of things, is that patients will feel as though they may not have had a benefit from the technology because they feel like the benefit is something that they did. And so helping them get to those goals, I like to give the analogy of, the M-Sculpt treatment that we have that will help with muscle growth and development. And it's the technology that uses the high definition electromagnetic energy to cause those muscle contractions that you can't achieve on your own, and do the equivalent of 20,000 crunches in a half-hour session or 20,000 squats in a half-hour session. People get stronger and then they want to go do more. It's like a jump start. It's like having a trainer, for 6 weeks to get you up, get you caught up to speed, and then letting them let you go on your own program. You don't always need someone there with you, but you need someone to get you that boost. A lot of patients are coming in and having this done with an aesthetic goal in mind, having a flatter tummy, having a more defined abdominal muscles. But a side benefit, which is actually a key benefit going forward, is that strengthening of their core so they can maintain and keep this up. It's just like it's an extra boost. And then once you feel that, you just like when you exercise and you get that endorphin rush, you want to do it again, and you want to maintain those results.
You spoke about something, and I'd seen it on social media where I think it was a lady sits in her urinary issues. And you had said something about the core to the floor with the pelvic. What exactly was that about?
Yeah.
Super cool.
Yeah. It's a recognition that, again, largely born out of changes related to pregnancy. And so when a woman is pregnant and that, baby is growing and expanding in her uterus, that causes changes to the body. It causes changes in accommodation to the muscles. And I think most commonly people think about the abdomen, right? Because that's where you see the belly, and you can understand that, yes, those rectus muscles that you see in people with six packs are going to be moving off to the side to accommodate that growing uterus and baby as they get bigger. But what happens to that muscle then afterwards once the baby's delivered? It never quite comes back to the, initial place that it was prior to pregnancy. Now, the more pregnancies that occur, if it's a larger baby, if it's multiple babies, then we see even greater exaggerated effect. And so the core to the floor analogy and description is really more about that. It's not just your abdomen, it's also the pelvic floor that stretches out. And one of the major changes that can occur after pregnancy that's not often spoken about in larger circles is urinary leakage, urinary incontinence due to the strain of those pelvic floor muscles from having not only the pregnancy, but even from childbirth. That's something that honestly, as a physician, I didn't have sort of good understanding and knowledge about. And it largely came about from our own personal experience. And after, my wife having our three children and some of the challenges that she, advised me on, that's what, prompted her to try the technology. And then lo and behold, this works. And again, that's the equivalent of about 12,000 Kegel exercises. Women who have had these challenges are told, by their family physicians, by their obstetricians and gynecologists that, do Kegel exercise, it'll get better. But there's only so many Kegel exercises that an individual can do. And so this technology called MCELA, which again uses the electromagnetic energy to really tighten and strengthen up that pelvic floor muscle, does the equivalent of 12,000 Kegel exercises in a approximately 30-minute treatment. And so you basically come in, they call it the throne, you sit on it, it's not painful, it's not uncomfortable, and you feel a bit of a vibration, and it's going to basically, contract and tighten up those muscles while you sit there and read a book. You can't be on your phone, you can't be on technology, because it basically uses MRI technology. It's like the safety of being in an MRI. And so I say it's a good time to reconnect with an old book, go old school, and maybe get a half hour of quiet time to yourself.
Wow. Now, I was reading something where it says that any gender, it can help with erectile dysfunction
Yes.
and something about increasing the orgasms. Is that true? Or,
Yes, and so that was actually, it came up as a side
mhm.
benefit, something that they weren't intending for as a benefit, but they've seen. So certainly men have issues with urinary leakage as well, and so that pelvic floor muscle, and it can be just as a part of aging. It can be a part of after certain surgeries, such as any prostate related surgery, and this is a common surgery for men as they get older, and a common complaint for men as they get older. It can lead to issues with erectile dysfunction. And again, building up that pelvic floor musculature, stronger erections. And that's actually because there's more blood flow brought into the area. And then some women will report having improved orgasms as well, again, due to the blood flow, due to increased lubrication. And so again, a lot of side benefits, a lot of sexual health benefits, a lot of benefits with no real downside.
So Dr. Chahal, you're doing quite a bit. You're in the hospital, you run this clinic, full-time dad, and all of these things. Now you have this rapid access clinic, hand clinic. What exactly is that?
Yes, part of the Calgary Plastic Surgery Center is the Rapid Access Skin Clinic we have, and that is a clinic that we endeavor to see patients who have skin cancer or have been identified having irregular lesions that are precancerous and that could be cancerous. We like to see them within 1 to 3 days, with a plan to have their surgical excisions performed within 2 weeks. And that's largely born out of a great need that we're seeing, and the inability to see these patients in a timely fashion through the hospital system. Again, it's completely covered under the Alberta Health Insurance Plan and is at no additional cost to patients or their referring physicians. It's just something that we saw a need for. It's something that I have a special interest in. I don't think that it's fair that if someone is told that they have skin cancer or have something that could become cancer, that they are left waiting months and months to either be seen by someone and then have it treated. And so we want to get people in a safe and timely and efficient manner to get those worrisome things off their mind and let them move forward.
I appreciate your time today, Dr. Chahal.
Well, thank you. I appreciate your time. Thanks for having me on.